Some people are afraid if you teach somebody how to do something that they will steal the procedure from you. Now, I can certainly understand that, but my thought is, if I taught you to do something and maybe we're in the same area, I think this is probably one of the best pieces of advice somebody gave me, who's initially actually motivated me to get into the OBL space, which is you can't steal second if you don't take your foot off first. Meaning, you really need to be willing to jump off that base to get to that next base.
I am here with my good friend Sandeep Rao, Dr. Sandeep Rao of Ally Medical, and I don't know if I'd be sitting here today at OAS if it wasn't for an introduction you made for me about 2 years ago to get me out to speak here, so I'm just grateful to be here, and thank you. Tell me a little bit about your background getting into the IR space. I feel like you've had an interesting journey.
Yeah, so I've been an IR doc for 15 years now, mostly on the hospital side for the initial part of my career, but then I've slowly started pivoting to doing OBL, outpatient work, and now, really excitingly, in the last year, I've really started going in the direction of doing in an ASC, in an ambulatory surgery center. So, and it's all started off with some cases I started doing more initially in the peripheral arterial disease space, but then we kind of started gravitating and doing more embolizations, and now I'm doing a lot more pain stuff. So it's really just a career arc of just evolving, adding more cases, and just kind of keeping up with the new stuff that's coming out.
I love talking to you because it's funny, I feel like there's this curve with the IR docs, and there's some that like they don't want to be the last ones to do it and don't want to be the first, and there's some of them, and everyone's in the bell curve. I feel like you want to be the first. You're always wanting to research.
I want to be on the tip of the spear.
Yeah.
That's my goal. I want to, if I hear about a new procedure, I want to find out how to get it out to our patients. Because some people, they wait a long time and then they wait until there's a ton of people have done it. But if I start hearing about a procedure that's been done in Japan, I mean, in fact, the way I started doing a lot of some of my stuff for musculoskeletal, I met one of the top guys in Japan, Dr. 𝐲𝐿𝐼, at this meeting, at the OEIS meeting, and he was telling me how he was doing it, and I started bringing out plantar fascia embolization.
Yeah.
So that's kind of how I'm doing. Like if I hear about something exciting, I'm like, okay, I've got to figure out how I can bring this to my patients.
I was just reflecting, at a different company, but like 3.5 years ago, sending you patients, and you're coming back like, okay, no, they have to have this pre-existing thing, and then we like, nope, just kidding. We were like refining that,
yeah.
And here we are, and people still just learning about GAE when we were doing it, almost 4 years ago now.
Exactly. I mean, a lot of things that people think that are very new to probably the vast majority of this crowd. The beautiful thing is working with you. Like, we've been doing it for a much longer time, so we've had a chance to kind of figure out who these patients are, who qualifies, who doesn't qualify. So we have this huge depth of knowledge that a lot of people don't have. So,
no, it was just fun to reflect on that. And I would say that I would wager, I don't know this for a fact, but I would wager you've probably done more GAEs than most of the providers in the space.
Oh, I definitely think so. Yeah. You'll go around asking people, like, they'll say, oh, I do a lot of GAEs. Then you'll actually ask them how many they did, like say in the last month or last year, and then you'll go, oh, okay. I don't want to, I try to be humble. I don't really tell them how many I do, because you don't want to really put yourself out there. But go, oh, okay, that's good to know that other folks are doing it. But you'll realize, oh, we've been doing like almost 400, 500 a year, right? Like you realize we're doing a huge amount, and then there's people who always think that they're bringing new stuff in, but it's always good to see a lot of people adopting it.
I'm just laughing because someone, in one of my slides I always put when I speak here, it's like, I'm not saying this to impress you, but to impress upon you. And I say that I'm probably booked more embolization direct to patient than anyone else.
Yeah.
Probably just through you. I could probably use that claim just on that. But anyways, I want to go to what is next for you. Like, I know we've been talking about neuropathy, and there's so many things coming down. What is exciting you right now?
So there's two areas. I would say the one thing that's already in our wheelhouse inside the procedures that I've been doing for a very long time, but now it has a lot more applications, is in that neuropathy space, in that failed back surgery space. It's basically just offering patients a treatment option for that pain. So I can give you a good example
Yeah.
of a patient that you sent. So thanks for that. Just 3 days ago, okay? Patient came in that you had sent me for just a workup for knee pain, for GAE. I'm going through the talk with them about what they're doing, what's bothering them, what other problems they have. And then you realize this patient also has issues with painful neuropathy. They've also failed the medication that you're supposed to normally try out, gabapentin, Lyrica, for a number of years. And they're an automatic candidate for spinal cord stimulation, which is a huge development area that is out there. And so to me, it's all about recognizing, and I have a talk about this actually tomorrow, it's about recognizing the patient's lifetime value to your practice. A lot of people see patients as you're paying out maybe a marketing fee, and they see it as a cost. Getting that patient as a cost. I see that patient as an asset. And how can I get more value from that patient to my practice, and how can I also provide that patient more services so that way they don't have to go searching in 5 different directions for a pain doc, a vascular surgeon, a doc doing something else. So that's where this patient comes in, where now I'm able to not just take care of one issue out of many, but I'm also able to take care of maybe their neuropathy. And that's where being in multiple sites of service, not just having a office-based lab, but also having a ASC plays out. Because there are certain procedures you might know that you can do and is paid for in an OBL, but may not be paid for necessarily unless you don't have an ASC, like the neuropathy, some of the spinal cord stimulator, the implants, you have to do it in that setting. But you can do the trial obviously in an OBL, but the point is that by looking for this disease, looking for problems that patients have, and expanding your own offerings, just don't stay in your little silo just doing PAD work. Just don't stay in your silo just doing GAE work. There's some folks who are like, I just want to do this one thing and just do it and do it and do it. But by offering other things, you're actually able to offer more to the patient.
Well, and I mean, as someone who's not a provider, I just amazed by the IR space because I get to see the alternatives. I mean, as a marketer, I'm like, hysterectomy, uterine fiber, all these things. And once you've amazed them with the outcomes on one thing, there's that story that Rachel, maybe she's over here, talks about, like she was sitting next to someone and they're like, what else can you do after their procedure? Because they're like, I didn't even feel anything. And I think so many providers miss that.
Absolutely. So this patient's a great example. I only spoke about the patient's GAE and neuropathy. I started looking at the patient's medication, and I noticed this patient's also on Flomax and finasteride. And when you actually dig a little deeper, he's like, you know what, actually, it also bothers me because I will have to wake up multiple times and not to urinate. But that's like problem maybe 7 on his issues. His biggest issue is the fact that he's got burning pain in his legs. He's got knee pain. So I was like, you know what, I actually have something for you, but let's get to that. Let's get to that bridge after we solve problems 1, 2, and 3, and then we'll get to your prostate. But that's the nice thing, is that there's so many different things we can offer in the outpatient space as an IR doc, doing endovascular procedures, that if you go looking for it and you offer it, and you have these offerings, there's no reason to turn away a patient.
Well, I think that the interesting thing that you and I have worked a lot on too is when you expand your offerings, it eliminates as much filtering. So, for instance, if you only have GAE, then yeah, you're going to have this very specific case coming in. But if they've got pain and you can help pain, the world's your oyster. Everyone's someone you can help.
Exactly. So I don't really try to brand myself as just a one procedure type of doc. My goal is to have as broad a net. And so that's why we sort of go under the pain and vascular sort of space. So that way, it's not just knee pain. There's some people who would like to say, oh, we're just a knee pain facility, or we're just a leg pain facility. But once you just say the umbrella of pain, there's so many different things that can cause people pain.
Now, how do you feel? I mean, so you're doing like the spinal cord stimulators, things like that. I know a lot of IRs, especially coming from like the leg wound, limb salvage stuff, that kind of scares them getting into that range. What do you talk to when someone asks you about that? What do you tell them in that regard?
Sure. So one is, it comes down to your confidence level in general, just doing procedures, and in your ability to maybe, are you willing to push the envelope on what people in your field traditionally do? That's one thing. Because I can tell you, so in my neck of the woods, there are folks I do know vascular surgeons who are doing spinal cord stimulators and doing prostates, but that's not the vast majority of docs out there. When you talk to people, they'll be like, you know what, that's not really in my scope of practice, and they want to say, we don't want to do it. Well, that's where actually partnerships work really well. You know, so there's a cardiologist that I work with. He has a ASC, and he's got a huge patient population. I work with him to identify within his practice all these patients who have all these other problems, and then I'm able to bring my services to his center under his umbrella. So that way, if you have the patient base, you can probably team up with another doc in your area who may be more comfortable doing it, and then now you're expanding the umbrella of offerings overall, right?
Careful there. You're starting to sound like you're doing business, not just medicine.
Yeah. So I mean, that's part of it, right? I mean, it's when you're in the outpatient space, it's all about, one is just in general, you want to kind of reach out to other docs, right? You don't want to just be working on an independent island, because when you have a problem, when you have an issue, you want to have other docs to be able to rely on. So when you start reaching out to your fellow vascular surgeons, your cardiologists, your other IR docs, pain docs, wound docs, on a certain level, I could potentially do a lot of this. I mean, I'm also board certified in wound care, but I don't even have time to really even deal with that. So I still rely on a doc for wound care. So having those types of relationships that it can, you know, they get to benefit, our patients benefit, I send them back patients. It works really well. And I think, to me, that's the beauty of a meeting like this. It's all about networking. This is not just an IR, OEIS is not just an IR only meeting. There's IRs, there's vascular surgeons, there's cardiologists, and they're all under the same umbrella where we can pick each other's brains, see, you know, who's working well with who.
Well, I think that I love that you've always been forward thinking like that. I think there's actually a vascular surgeon we work with, I think Dr. Pollock, like learned to do embolizations from watching you. Now, he had an IR background,
yeah,
but it's just interesting to watch that, like, what you guys are doing here at OAS, like, that's how he learned about it, and it just went down a whole different pathway. Do you enjoy teaching the different aspects of things you're doing? Like, you're speaking here, is that something that's a passion for you?
Sure, I think it's great to, you know, get the word out. You know, some people are afraid if you teach somebody how to do something that they will steal the procedure from you. Now, I can certainly understand that, but my thought is, if I taught you to do something and maybe we're in the same area, the same region, if all of a sudden I start losing patients to you, it can mean one of two things. Either A, you're just doing the procedure better than me, and in which case maybe the patient actually is probably benefiting, or you're probably marketing better, which means I need to, like, market my services better. So to me, I'm of the opinion, I think competition's good, it's healthy, and I think there's enough patients, honestly, to where even if you took a bunch of patients, there's enough of a pie out there, and the pie is rapidly growing to where I don't think my bottom line of my practice is going to hurt, because I'm not going to lose patients or lose a volume of patients.
It's funny you said, I actually know two providers that are in a similar area, and one has contracts with these three insurances, one has this, and so they end up like referring each other patients, and
Sure.
they're in theory competition,
Yeah.
but it's like, I can't help this person, I might as well, and so they feed each other, and it's just really funny to watch this weird rivalry,
Yeah.
symbiosis thing where they help each
Yeah.
other at the same time.
Yeah, it's great to see.
So now, you've always been strong in marketing. I know you did radio back in the day.
Yeah.
What are some of the trends you're seeing in marketing as far as all of this stuff kind of going on?
Yeah, so I'm not back in the day. I still do radio. I still host a radio show. And that's, you know, it's all about the question of, do we want to rely on legacy media? Because I kind of grew up in that, you know, I grew up listening to the radio, like, throughout, you know, like, all my life, like, listening to a lot of talk radio growing up with my parents. And I still love listening to that type of radio. And I still read newspapers. Maybe I'll go to the more digital version of it. But obviously a lot of stuff is going digital. Everything's going towards social media. The vast majority of my practice is actually growth through social media. So I think for sure we're going in that direction. I think if you were to say bang for the buck, if I'm paying $1, would I rather have it go to a traditional legacy media campaign, whether it's TV, radio, newspapers, print, versus digital? I think the best bang for the buck is on the digital side. And so I don't spend any money on that side. Even though I'm on radio, I don't spend money advertising for patients on the radio. When I do my radio show, it's really about building my personal brand. I like just to be known in the community as somebody who, I'm not just talking about my procedure. I'm talking about other procedures. I'm also interviewing guests who offer other services. It's basically it's a overall medical talk show just to get the word out about medicine, new technologies. And so, but I'll be honest, I don't really believe in it from an advertising standpoint. I really think it's the digital space which is far more valuable to practice growth.
So obviously for us, we do your direct Instagram, Meta, and
Yep.
the appointment setting. What are your other top forms and methods that you see that are working for you digitally?
Well, to me, I think that's the majority of it, right? I mean, it's the Instagrams, Facebook, Google. Beyond that, I don't know. Are there? Because here's the thing, right? I don't know enough about the digital space. That's why I rely on folks like you to tell me that. I actually should probably ask you that question, right? Like you send me, whenever I talk to a lot of folks in the marketing space, I always say, okay, how much budget are we allocating to the Google ads? How much are we allocating to Meta ads? And in my particular area, I found probably a little bit more patient for that $1 that I spend. I think I'm getting more leads from Meta ads. Now, that's in Central Texas, in San Antonio. If we were to go move that to my other practice in El Paso, I don't know, it might be very different. But I'm also, be honest with you, in El Paso, in West Texas, I'm not doing any digital ads because I have a really great partnership with a doc who has an existing database of his own patients. So I don't feel like I need to rely on it. I don't need to spend that money. And that might be a totally different number in Austin, which is a very tech-savvy city. So honestly, that's probably something for me to find out. But I don't try to get too much into the weeds on the digital side because I don't have my pulse on it as much as someone like you.
I mean, that's also why you pay
yeah,
us, so we can put our finger on the
yeah,
pulse.
exactly. Yeah.
I know that one of the things that's, as a provider who's seeing consults, getting people to show is always the big challenge, right?
Oh, yeah,
It's,
for sure.
you don't want to sit there for a clinic day with no one coming up. What are some strategies over, we've been working together for almost 4 years. What are the strategies that you see that have really helped make sure there's a patient in front of you?
Oh, that's great. Yeah, so that's a great question because I do see your leads show up. And my goal is always to maximize those patients who've said, I'm interested in a procedure to actually showing up, right? And so to me, the first thing is minimizing the amount of time from identifying this as a potential lead, as a potential patient, to us contacting them. So I have a really strong manager who calls these patients as close as possible to the initial inquiry. So that's a huge one. Another thing is just making sure that we also kind of get a sense of how far the patient is from our clinic. We have a sense of, oh, you know what, there are some patients who are probably inquiring about it, but they're a much further radius away. What's the chances that they'll show up? It may be a little lower, but if they're like really close, because we kind of are in a bit of a healthcare desert where I am, in a sense that I don't have too many other competing docs. And so if they're really close, there's a great chance they're gonna show up if they have a problem. Now, another thing, and this has really been helpful, especially on procedure days, because sometimes you have a patient who makes the initial inquiry online, then maybe they show up to clinic, but what about the no-shows on a procedure day?
Those costs.
Yeah, exactly. Because you have a list of, 4 or 5 patients you want to do, and if one doesn't show up, you're just sitting there twiddling your thumbs because you don't have anything else going on. So one thing we've really tried to change between myself and my brother, who also works with me as an IR doc, is we try to make phone calls, not just from a clinic manager standpoint, but I do a personal phone call myself to that patient the day before, so that patient knows that not only are they invested in getting a procedure done, I myself am personally reaching out and making sure that you are comfortable enough to come in the next day for the procedure.
It's funny you say that because I think so many docs will be like, well, I open my own practice, I have people for that, but you spending 30 minutes to guarantee that you have all your cases show up versus wasting an hour the next day or 2 hours,
sure.
That's such an easy trade-off.
Oh, absolutely. Something that I didn't even realize until, interestingly, my brother, who's an IR, as I said, was a patient. And he had a doc call him to his outpatient center, and he goes, look at how much of a difference it made. Like I just got so much more comfortable about showing up the next day for the procedure because the doc took the time to make sure that I'm coming in, that we're on the same page with the procedure, and I don't want to disappoint him by like not showing up at the last minute. So I'm going to show up. So I tend to do that for my patients.
I love that. I hope if anyone takes the nugget away from this call, is docs, call your patients the day before, make sure, and especially if you're stacking procedures, and you want to go bang to bang bang.
For sure.
So on that note, you said something, I'm trying to remember where I was going with it, was stacking procedures. Now I know you're really quick in the OBL and you're very fast, but when it comes to layering procedures, because you're doing a lot of different stuff, how are you scheduling and making things work to where, are you stacking GAEs and then PFEs or different days?
So we actually don't do that. If you said in an ideal world, yes, it might make it very easy to stack a bunch of the same type of procedures back to back to back. But also on a different level, it's kind of nice to have maybe a very quick case, sometimes in between those. Because let's just say one of those cases ran overtime. And so then, let's say it's a PAD case. So, I definitely have some PAD cases coming in. So sometimes having a bit of a break where I know maybe a PAD case is not as expected from a time perspective, because you don't know if you're going to do groin access and maybe you need to do pedal access, which might add a little bit more time. I tend to also include a radial diagnostic during my peripheral arterial cases. So starting off the day with like a bigger case, and then you follow it up with some of these smaller, more expected time slots of, I know I can do this GA within an hour, or this plantar within even less time, or if it's a neuropathy case, you know how long it's going to take. Those are all very clearly defined cases. So mixing it up actually makes it a little bit better, because that way, if you do run behind on a case, you're not feeling like you have to catch up. Or sometimes we do have, still, despite all of our best efforts, we have patients no-show, right? And so then having a longer case,
fault. It happens to everybody.
Exactly. And having a longer case, sometimes you go, oh, you know what, the patient didn't show, it's not the end of the world, now we're not going to have a wait. So we do keep very strict track of the metrics of how quickly we get in and out of a room, how quickly we're turning around the patient times, just so that we're not out there wasting our time.
I said that and I realized there's probably a lot of docs watching going, wait, he's doing multiple procedures a day? Like, that's a blessing that you guys have, that
for sure.
Not everyone's getting to, not a problem everyone's dealing with.
Yeah.
So I know you're doing the neuropathy, you're doing, you're doing knee. Have you played with hips, back? I said obviously you're doing the stuff for back. Shoulders, like what are some of the other embolizations that you're playing with as well that maybe aren't as well known?
Sure. So in just the musculoskeletal embolization space, my sort of initial entry, my initial foray into it was through the knee. But I've done shoulders, I've done plantar embolization. I've had colleagues do hips for bursitis. The issue is, how am I going to identify those patients, right? And we're sort of going right now, I'm relying significantly on digital marketing. And so I'm spending X dollars, and really we're just kind of doing it in this one area. But if a patient has those other issues, I find those other issues, or a doc sends those other patients to me, I can easily do a shoulder embolization, a knee embolization, plantar. The stuff that's sort of on the periphery that I really want to get into, I would say, is there's this entire area with thyroid embolization, which I think is going to be sort of a next big thing that I really want to get into, because we recently got approved for there were some codes that were developed for that. There was a lot of talk at the Society of Interventional Radiology meeting just a couple months ago in Nashville about folks doing it. And I think it's ripe for movement into the outpatient space. It's currently being done mostly on academic centers that really developed it, but I think it's ripe for movement into the outpatient space. I think thyroid embolizations for people who have very enlarged thyroids that don't want to get a big surgery, don't want radioactive iodine treatment for those patients. And I think another big area that I'm looking forward to, probably if you said the next year, is the area of renal denervation for patients who have high blood pressure. We're kind of waiting on a national coverage decision from federal payers on that, but I think that could be an amazing area, a huge area, because if you look at a patient who comes in, the vast majority of them might have high blood pressure in addition to having all these other issues going on with them. And so now if we can also offer a treatment for dealing with their high blood pressure in the outpatient setting with denervation, that's something that could significantly take off.
So a lot of our audience are IRs and nerds.
Yeah.
So talk me through like maybe a super high level of how that procedure actually works.
Sure, so renal denervation is basically a way to go after the blood vessels, the nerves that are surrounding the renal artery. And what you do is you're able to put in a little catheter, almost like you're doing any angiogram. You put in a little catheter, a little wire into that renal artery. Most of us might have done renal artery stenting for patients who have renal narrowing leading to high blood pressure. So don't want to get into the physiology of how the kidneys impact blood pressure, but the kidneys are probably the most important organ for monitoring and improving your blood pressure. Because if your kidneys, there's a lot of blood vessels that are, a lot of nerves that ride along the blood vessels to the kidneys. And if the kidney thinks that your blood pressure isn't high enough, it'll start artificially jacking up your blood pressure. So what we're doing is we are tricking the kidney or making sure the kidney does not overreact to signals sent by the brain to increase your blood pressure. So what we're doing is we are basically denervating the renal arteries, okay? We're taking that nerve impulse that the kidney has to wanting to jack up the blood pressure. And so what you do is pretty simple procedure. You put a wire into the renal arteries, and it's a special wire that is able to send signals to those nerves that are in that adventitial space, in the periadventitial space, and destroy them to where now those nerves are not going to send the signals, so then your blood pressure should come back down. It's a pretty quick procedure that's been done. They're doing it quite a bit in Europe where it has more approval, but now we're just kind of waiting to get full approval in the US. So right now there is some code available for it to be done in a hospital setting, but there's still some challenges to getting it approved because you have to ask for it on almost an individual basis. But we're pretty much ripe. I think probably we're saying maybe in October, November, we might start seeing dedicated codes for this.
Do you think it'll, like what will it reimburse similar to, do you think?
That I don't know yet. I mean, that's like still, that's pretty far away. Right now, I'm just, honestly, to me, I think this is like an amazing, I'm just looking at it from a patient care standpoint.
I mean, they never have to, they don't have to take medication for the rest of their life, which most of them probably are
Well,
on.
so it's actually not that. So this is actually quite interesting. And if you really go into the avenue of blood pressure, if you have super high blood pressure, let's just say it's 180s. I actually had a patient who came in 180s. He was coming in for actually a knee embolization, had 180s blood pressure. I'm not looking to get a patient down from like 180 systolic down to 120. I don't know if you know this, but if you just decrease that 180 to 170, which is still high blood pressure, just by decreasing it by that 10 points, you're actually having significant downstream effects on that patient's life. Just that 10-point reduction. And so that's what this denervation does. It's not designed to go from 120 down to 180 down to 120 over 60. It's not designed to get perfect pressure. We're just trying to change that patient from 180 to 170, 170 down to 160.
It's like,
just that alone makes a massive difference in mortality and stroke.
It's like a 10% reduction in body weight, like diabetes, everything, lifetime, you add years to their life for that small change.
Exactly.
Well, and that kind of transitions to my next thing, and you and I have talked about, is the future of the bariatric embolization, which I have that huge background in weight loss. So I'm excited to see, are you seeing that? Do you think that'll ever go federal reimbursed, or do you think it'll stay in the kind of cash pay experimental?
Yeah, right now that's where it is. We don't have the full approval for that. It's not completely recognized.
It's been around for a long time.
Yeah, it's been around for a while. I think the difficulty there is, one is just getting more and more data, and so people are accumulating data. Once you start seeing the data, I think then you'll start maybe seeing more, approval, more folks adopting it. Right now, I'm not seeing too many people going into that space, largely because there's this huge drug called Ozempic.
Yeah.
These huge areas of these semaglutides, these GLP-1s that has sort of taken the country by storm. And so people are getting great results with it, but it is expensive, we know. We also know that some patients can't be on this forever and ever, and they're just on it for maybe a year while they're getting their weight covered or their weight improved. But we do want things to bridge them, and I think this is where that could easily fit in. So
we have I think we work with, there's a doctor in California, Dr. Patadar, and he has a lot of specialty in the weight loss space, and he's doing some of these cash pay combined with other modalities, and he's doing pretty well from it with what I've seen. I don't know how many cases he's done, but I just know he's the only person I know that's actively doing consults for it right now.
Oh, okay, cool.
Well, what is your talk? So last thing I wish my end here at OEIS. So what are you speaking on today or tomorrow at OEIS?
This is a busy OEIS meeting for me. I'm giving 5 talks starting tomorrow. Okay, so I think the top talks are the main thing I want people to get out of this whole meeting, and I'm covering it based on 2 talks I'm giving. One tomorrow on, which I kind of started this discussion with, about the lifetime value of patients, and the second thing is about adding new patients to your practice. So I'm giving a talk on plantar fasciitis embolization and also on spinal cord stimulation. And to me, I think the overall sort of theme with this whole meeting for me is that I really want to get to people is, don't just be stuck in your single silo just doing GAEs, PAD. Add other procedures to your armamentarium, because really then you're able to keep any patient who comes in your ecosystem. So if a patient has knee pain and the insurance isn't paying for an embolization, by offering a nerve stimulation procedure, you're still able to keep them within your practice. You're not having to send them out. And same thing if you have a patient, they have knee pain, sometimes they start walking weird, then they start having plantar pain. I can do and offer plantar fascia embolization if they failed conservative therapy. Again, you're keeping the patient within your practice. They're not leaving. Going back to my main point, which is it's all about maximizing the lifetime value of this patient, right? It's all about making sure that this patient is valuable to your practice. They're an asset to your practice. You want to keep that asset in your practice and not have them go elsewhere. And by providing them as many services, the patient doesn't have to run around for these treatment options. Because a lot of these patients, they don't know what's out there. These are all new technologies.
Their doctors don't know what's out there.
Exactly. No, very few people know about them. So by being able to constantly educate your patients about what's new, what's out there, the alternatives, you're really able to give them the most value that they have for that interaction that they have with you and the value that they bring to your practice.
That's awesome. All right, I ask everyone this. If you could go back to when you first opened your OBL, what's one thing you would do, what's one thing you would do or maybe one thing you wouldn't have done differently? Does that make sense? Like knowing what you know now, if you could go back and open, like what would you do different?
That's a great question. What's one thing I would do or not do differently? And the reason that's interesting is because I'm constantly opening up a new facility, so I'm almost having to constantly think about that. Because 5 years ago we kind of started our initial little thing in Phoenix, and so that was one start. But then about a year ago we had to reboot in San Antonio. It was almost like a new OBL facility, and so I had to kind of use that, what I learned, to start this one. And so
They're
I was
like
able
kids, right? You're
exactly,
like, oh, I know what I'm doing now.
Exactly. And so, but each of them is different, right? Phoenix is different from West Texas, is different from Central Texas. So many things are different, but one thing I would say is, I think this is probably one of the best piece of advice somebody gave me, who's initially actually motivated me to get into the OBL space, which is, you can't steal second if you don't take your foot off first. Meaning, you really need to be willing to jump off that base to get to that next base. And so what I've done in the last 6 months, from a pure practice standpoint, is I've significantly reduced my commitment to the hospital. Because what that's allowed me to do is, I've been able to be more fully committed to my OBLs. On a certain level, it has also given me more free time inadvertently, because sometimes a facility may not work so well. But by being able to pivot on a dime and go, you know what, this facility is not doing well, I need to commit more time to this facility, I'm able to make that facility grow. Because if you just always have one foot on first base, and to me, I always use hospital as your first base, because everybody who comes in from training, they start off in general in the hospital setting, and they're afraid to take that foot off that first base. They're afraid to take it off and start running to second, to go into your initial outpatient space. So the quicker you're able to do that, and for me, the confidence came over these years because I started realizing I can make that leap, I can make that jump. And also, I'd built up my personal finances over a period of time to where I felt like I could take a bit of a loss by not having steady work in a hospital setting.
Probably helps that you can go direct to patient, not have to wait on referrals.
Exactly. And the whole digital marketing thing, which you introduced me to, was also super critical because I felt like I had to only rely on docs to get me these patients. By being able to realize I could be more independent, I felt like I could really take a jump and make that leap to second base, to the outpatient space.
Well, dude, it's been fun to watch the journey, and thank you for bringing me along, because I mean,
Sure.
like I said, we've been kind of hand in hand on this. Dr. Ralph, if someone wants to connect with you on LinkedIn, what's the best way to find you?
Sure. So I feel like I probably at this point have a pretty. There are some people who try to be ungoogleable. I've heard about this, but people trying to be more anonymous. I think I'm pretty easy to Google if you put my name. You can easily find me, but you can always reach me by email. My emails, I have multiple emails for each of my practice, my personal.
Find him on LinkedIn, Dr. Sandeep Rao.
Exactly. Or just Google me, and I'm sure my Instagram will pop up. I'm sure my LinkedIn will pop up. I'm sure you'll find out my hospital practice, my outpatient practice. I want to be as available to patients on the internet as opposed to people who don't want to be available.
I don't want to inundate you, but I will say I have never met someone that was more willing to talk to a doc and help them out. And so I just appreciate all you do for the space.
Thanks.
Thank you for being on, man.
Thanks. I appreciate it.